Now we'll move on for our next panel discussion. And for that, we have our moderator, Dr. Mikal Khanna, who is the physician and diabetologist. At his area of interest are in diabetes and COVID, prediabetes, diabetes, and nephropathy. He has been the speaker of many webinars in the topic of COVID and diabetes, verified trial, OSA, and diabetes. So I welcome you, sir, and I request you to introduce our panelists. Over to you, sir.
Yeah. So thank you, Dr. Mayur Patel and Dr. Yash Patel and the SwasthyaCON team for inviting me to moderate this session. So I invite all the panelists here, Dr. Urman Dhruv, Dr. Manoj Vitlani, Dr. Sunil Mehta, Dr. Sanjeev Pathak, and Dr. Ashwin Gandhi from Ahmedabad. And I invite all of them to start this session.
Good evening.
Good evening, Dr. Urman Dhruv.
Good evening, Dr. Mikal. I think our videos need to be enabled.
Can you hear me, Doctor?
Okay, fine. Yeah, we can. Yeah, we can hear you, and we are all. You are audible.
I start the
good evening.
Please. I'm
Good
Dr.
evening, Dr. Mikal. I'm Dr. Manoj Vitlani.
Yes, Doctor. Good evening, Doctor. Nice. Hello, Doctor.
Welcome to all of you, please. Yes, Manoj sir, Urman sir, Sanjeev sir, Sunil sir, you all are audible, and go ahead.
Yes.
We are eagerly waiting for you.
Yeah. Can I start the session?
Yes.
Sure.
Yeah. So first of all, we are this thing that COVID-19 is the most unexpected pandemic which has occurred in the history of mankind. The 2020 year was the most dramatic year where I think the whole mankind, the medical fraternity in general, has risen from the like phoenix from the ashes, and the medical opportunities which have been given to amalgamate or combined clinical teams have come together to help our patients and help the community in general. Now we all know that diabetes is basically a state of decreased innate immunity, and also there is this thing, the pro-cytokines are decreased. Also there is down regulation of the ACE2 receptors, and when there is COVID in that case, so COVID in general leads to beta cell defect and beta cell insulin resistance. Also use of drugs like steroids worsen the diabetes control. So basically we'll have a very healthy session of a dialogue between our speakers and myself, and we'll walk through this road. Basically it is a knowledge in progress, which I should say. So I'll start with our question answer session. It will be a dialogue between our speakers, and sir, I will start with the doctors.
Sir, you are not audible.
I am not audible.
Sir, you are audible. Please go ahead.
Okay. Yeah. So I want to ask the question to Dr. Sunil Mehta, sir. Or saying, are people with diabetes more likely to get COVID-19? Dr. Sunil Mehta.
Thank you, Mikal, and thank you, Mayur bhai and Yash bhai, for inviting me for such discussion. The common belief would go like this: that yes, the patients of diabetes are more prone to COVID infection. But our study of about 8,000 people, we haven't found that way. Most of the people are of common age group with common diseases. We haven't found anything which is favoring the diabetes causing more COVID infections. But however, saying that, I would also say that those who are diabetic, and if they get a COVID infection, the likelihood of their recovery is slightly stormy compared to the other people. So that way the diabetes is important as far as the COVID is concerned. But as far as the preference of disease more in diabetes, that we haven't found so far. So diabetes leads to multi-organ dysfunctions, leads to innate decrease in immunity. All these are very commonly known factors, but somehow in our study we haven't found that diabetes likely to cause more COVID infection.
Thank you so much. That's very enlightening. Now, my second question is to our eminent physician from Ahmedabad, Dr. Manoj Vitlani. I will ask him this question because he has got a lot of experience in treating COVID patients. So, do people with diabetes have a higher chance of serious complications from COVID?
Many
Manoj?
thanks, Dr. Mikal. Thanks to the Dr. Mayurbhai and Dr. Yas. This is a definitely interesting session because of the COVID-19 and the diabetes is much hyped. This is one of our experience what Dr. Sunil Mehta shared with you that we had seen many patients, nearly 25 to 30% of the patients having the diabetes already before coming to the hospital. And there are the many patients we had seen newly diagnosed diabetes, and many patients we had seen with the type 2 means steroid induced hyperglycemia, because after the first week of the illness, most of us we use the steroid to combat the inflammatory response and the early recovery, which leads to the insulin resistance and the diabetes, increase in the hyperglycemia like already suffering from the diabetes. And this is I am sharing with the one paper which recently published in the Annals of the Medicine of the 11,000 patients. They found that the nearly 20% increase in the mortality among the COVID patients with diabetes. Those and this they have fantastic. They put they're classified as the HbA1c less than 8.5, HbA1c between 8.5 and HbA1c 8.5 to 10 and more than 10. This is the three category in that article that they found that those who have mortality, especially those who have a HbA1c more than 10. So we also come across with the COVID complications, those who have already HbA1c more than 10 on presentation. But those who have a steroid-induced hyperglycemia, they behave like a routine COVID-19 patients, and the insulin is the only agent to combat the steroid-induced hyperglycemia. And once the steroid get tapered, and they found to have hypoglycemia if you have not taken care of or not given a good patient education. So the complications of the COVID complications in type 2 diabetic or type 1 diabetic may be driven by the baseline hyperglycemia. So this is an important observation, same as the universally found in the all over the world.
Thank you, Doctor. That was wonderful. The third question is, are the risks same in type 1 and type 2 diabetes? I will ask this question to the senior most physician, I think, Dr. Ashwin Gadvi from Ahmedabad. Yeah.
Maybe Ashwin sir is at present not available to us. We can go through to Dr. Urman too, sir. Urman sir, your mic is mute, sir.
Thank you, Dr. Yash and Dr. Mayur, and thank you, Dr. Mikal. Yes, the risk practically remains the same in type 1 and type 2 diabetes, and depends basically, as Dr. Manoj rightly said, the glycemia at the time of hospitalization or at the time of capturing the infection. So hyperglycemia at the time of hospitalization, if it is high, more than 300, then the chances of complications are more. However, the risk does not differ between type 1 and type 2 diabetic patients.
Thank you so much, doctor. Thank you. Thank you very much. My next question also is to a physician. I think Dr. Manoj Vitlani will enlighten this. What investigations, sir, are needed in patients having history of diabetes when he develops COVID in addition to routine protocol like CBC, etc.? So what are the investigations which are particularly important in a COVID patient, sir?
Many thanks, Dr. Mikal. This is also an important question, because this COVID-19 patient we had seen in those who were hospitalized patients likely to develop the prolonged course because generally hospitalization only to occur those who have a severe, moderate or moderate to severe disease. So in second week of the illness or the late first week, means fifth or disease, we are going to use the steroid in such patients to combat the inflammatory response. So steroid anyway going to increase the sugar levels. So already those who are suffering from the diabetic, baseline HbA1c is must. Usually we monitor by the finger prick blood glucose. So blood sugar on the day of admission, at least fasting plasma glucose once in laboratory and once postprandial level is very important to find in the laboratory. And HbA1c is must in all the patients, those who require the hospitalization in with the COVID-19. And
Yes.
another I would like to say about those patients having a diabetes with other comorbidity like hypertension, coronary artery disease, the hypertension especially, and the kidney disease. These patients we have to at least do the urinary albumin creatinine ratio, which is also an independent risk factor for the development of the COVID-19 with the increase in the chance of the heart disease related with the atherosclerotic cardiovascular disease also. So one has to this also keep in mind.
Thank you, Dr. Manoj. Next question is to again to Dr. Urman Dhruv. How do you manage a patient of diabetes in COVID ward? Since you are into diabetes, so this is a very basic question for all our listeners and delegates. How will you manage of diabetes in a COVID ward, doctor?
Thank you, Dr. Mikal. I'll be very brief because this is such a very long topic.
Yes.
It is not possible to collect the blood frequently once the patient is in a COVID ward because the phlebotomist cannot go frequently. So at the time of admission, we suggest a random plasma glucose to be collected in the laboratory simultaneously. A glucometer reading should be obtained to look for the glucometer variability and along with that HbA1c. If the patient is on SGLT2, they have to be stopped immediately, whatever is the glycemic presentation. If the patient has pyrexia, hypoxia, or the patient is to be posted on steroids, then the safer way would be to cut down sulfonylurea to half or to stop it completely and to post the patient onto 3-point or 5-point blood sugar by glucometer and shift the patient onto the insulin. If the patient is on gliptin, they may be continued. There are reports that sitagliptin is a better choice. However, you do not need to shift gliptin if the patient is comfortable on the current gliptin. So all gliptins are allowed, but if you are starting a gliptin as a fresh candidate, then sitagliptin is preferable because of more evidence. Otherwise, reduce especially glimepiride to half or stop it and post the patient onto the insulin. Especially the patients who are on steroids, we have seen and we all know that it is the post-food or post-prandial glycemia that gets exaggerated rather than the fasting hyperglycemia, and therefore just Dr. Mount talked that we should give basal insulin and then bolus insulin. This would be one situation in medical fraternity where the role of basal and bolus would be reversed. We'll have to give ultra short acting bolus insulin more frequently, while a very, very small dose of basal insulin. You can continue with metformin, give a very small dose of basal insulin at bedtime, and give 3 shots of a very ultra short acting fast acting insulin. This should be as ultra short acting as possible because we want to avoid hypoglycemia. Although most of the literature says that hyperglycemia in the hospital is one of the risk factors, most of the Indian doctors have not noticed this. Most of the time our patients remaining little hyperglycemic have not developed a complication. As I said, it is not possible for medical officer or nursing staff to visit the COVID ward patient frequently. It is safer to explain to the patient to go for SMBG on his own unless the patient is not able to do it because of his old age. Only in that case nursing staff would go. Otherwise the patient should be requested and advised to do the glucometer reading on his own. That would reduce the visits to his rooms frequently. Again, he should be properly explained, exactly explained the role of diet. The dietitian should be counseled properly along with the patient, and diet and fast-acting insulin matching, timing should match absolutely perfectly. The patient should be given a couple of glucose tablets along with him so that
biggest issue of COVID ward has been
accessibility of the patient by the COVID health worker. It is not possible to do it frequently. So once the patient is stable, he start taking enough food, the steroid doses are getting a little bit tapered, temperature goes down, oxygen saturation is maintained, the patient may be shifted back to at least sulfonylurea, not SGLT2 inhibitors. So this is in nutshell the management. One should always keep in mind, always keep in mind to look for urine acetone and serum acetone once in a while, especially the patient who were on SGLT2 inhibitor at the time of admission, or those whose sugars are fluctuating or swinging very high. I think this is where I'll stop because there is a lot more to say, but this is what an average physician should know. Thank you.
Thank you, Doctor. Yeah, I have this question for Dr. Yash Patel. Does COVID cause diabetes, doctor? Like, or Dr. Sanjeev Pathak, also Dr. Yash Patel or Dr. Sanjeev Pathak? Dr. Sanjeev Pathak? He's a...
Yes, I am here. But Yash can always add to what I feel. Well, my answer to that is probably yes. There have been papers coming from Italy, France, US. Still, we do not have any Indian paper linking the COVID with new onset diabetes. But yes, directly and indirectly. Directly, why? Because the beta cells are there and they have ACE receptors. And this coronavirus has got binding with the ACE receptors. So through direct mechanism, it is possible theoretically and mechanistically to have new onset diabetes, which may be having insulin deficiency. This we have seen in a couple of patients, but more than that, probably it is the unmasking of the diabetes due to the illness itself, the infection itself, the stress and the other factors, lack of physical activity for those 14 days or 21 days. So that also contributes to new diagnoses during this COVID illness. Moreover, as Dr. Urman Bhai rightly pointed out, so many patients receive steroids appropriately or inappropriately, but that also can exacerbate the hyperglycemia, which was previously unknown. So yes, COVID can cause diabetes, or at least it can unmask the previously undiagnosed diabetes.
Thank you, doctor. Thank you very much. Next question is to Dr. Manoj Vitlani, doctor. Is adrenal insufficiency common in diabetes patient in the ICU setting? How to suspect and manage such type of patient? Dr. Manoj, sir.
Thanks, Dr. Mikal. This is an important question. As per the literature, this is adrenal insufficiency in COVID with diabetes is rare. In fact, those who have a high baseline cortisol levels, more than 200 nmol per liter, or in a COVID with diabetes, is high likelihood of the development of the chance of the complication, nearly 40%. One head paper. I had seen the only one case report on Medscape that the one adrenal insufficiency occurred in the COVID-19 with diabetic patients at the age of the 69 years. And this rapidly fulminant means patient develops the hypotension, require the ventilator, and the severe dehydration in the after the 24 hours of the hospitalization with a normal hemodynamics on the admission, and then rapidly worsen after the 24 hours. These patients found to have a very low serum cortisol level, less than 12 nanogram per ml, and these patients required a hydrocortisone infusion after the first 8 dose, and then gradually recovered this patient. But generally in adrenal insufficiency in diabetic patient with COVID is very rare. One has to remain very watchful when there is your patient develop the hypotension, non-reversible with the multiple vasopressors. Patients rapidly worsening the shock, and shocks unresponsive. These are the two features you have to remain watchful in a patient of a rapidly worsening COVID-19 patient in ICU.
Thank you, doctor. The next question is a very important one. What important drug interactions will you keep in mind while managing a diabetes patient with COVID? I think Dr. Urman Dhruv.
Oh, thank you. There are multiple drugs one should always think about, and the important one is HCQS. One should always remember that despite the fact that HCQ has been rejected globally, in India it has been used by family physicians and lot many doctors at the beginning of the COVID infection treatment, and that causes a definitely reduction in blood sugar levels. So that is one thing that one should always remember: HCQS causing hypoglycemia. Number two is one should remember the interaction between favipiravir and ripaglinide. In fact, favipiravir when used reduces, potentiates the effect of ripaglinide and therefore causes hypoglycemia. So it is safer to avoid ripaglinide during treatment of COVID with favipiravir, whether in the ward or at home, that is more frequently seen. Again, another important thing is while the steroids are being used, one should avoid the use of the pantoprazole twice a day because that can also potentiate the effect. Number four is the drug domperidone or the drug that is being used for vomiting, that is ondansetron. When used with azithromycin, HCQS, they all have, and plus levocetirizine. These all drugs have potentially high affinity to produce prolonged QT. Levocetirizine, azithromycin, then the favipiravir itself, they all, ondansetron when used for vomiting, they all have got a potentiation to reduce, to augment the QT interval and can cause sudden cardiac death. So it is very, very important to avoid these drugs simultaneously. Again, adding antifungal drugs without evidence can also potentiate the QT interval. So these are the few things one should always remember. We should always remember that the anti-tuberculous drugs have also got important drug interaction with favipiravir. And lastly, but not the least, is when you use remdesivir, it has got a potentiation of hepatotoxicity or may cause hepatitis and can accentuate the SGPT and SGOT. And then one should keep an eye. And any drug which can potentiate this hepatitis-like features, so that should be kept in mind. Thank you. Over to Dr. Mikal.
Yeah, this is an interesting.
Mikal, can I interrupt you?
Yeah, no.
One important means when you use the remdesivir along with the HCQS, the efficacy of the remdesivir is reduced. So when you starting the remdesivir, at least patient must be off at least for 24 hours before starting. HCQS to be stopped before the remdesivir to be given.
Very important point. This interesting question. This thing: a patient of COVID with uncontrolled blood sugar, high fever, a normal oxygen saturation on 6 minutes walk test, can you avoid steroids in this? Dr. Sunil Mehta. Can I ask Dr. Sunil Mehta to answer this question, or he's around? Or for that matter?
Yeah. It is a very interesting question.
Yes.
It's a double-edged thing, you know. See, to get a high-grade fever in COVID is not a very usual phenomena. Usually, we get a low-grade fever,
Yes.
but
Yes.
on top of that, the patient has uncontrolled diabetes. So that adds to the fuel to the fire. So there is something happening in the patient's body that it is giving you a very high temperature. So it could be a cytokine storm, it could be a secondary infection, or it could be something else which is also developing inside the body, which is giving you a very high grade fever along with the uncontrolled diabetes. So we have to be very skeptical about using a steroid. But most CT scan or HRCT says absolutely normal without any GGO. Then we may wait for a day or two. Otherwise, the steroids are always on the card after 7th day of the disease, because that's when the cytokine storm starts taking in, sets in. So it is better to be now than never. That would be the answer. And provided HRCT is absolutely normal and PCT is very high, that is procalcitonin is very high, chances of secondary infection are very high, then we are bit delaying the use of steroid. Otherwise, we would use in every single patient of COVID, 7th day onwards, steroids. That would be my way of treating a patient.
Thank you so much. The next question is salient.
Sir, so now we have 2 minutes for the further session. So make it in a way.
Okay. Yes. So this is about role of immunization in a diabetic patient. Dr. Urman Dhruv or anybody, and I'll just yes.
Okay, it's very important. COVID patients are mostly older patients, more than 50 years of age, and therefore immunizing them against influenza every yearly, that instruction must go down to them, and simultaneously the use of pneumococcal vaccine. Both are very, very important. They should also be advised to avoid outside food, because these days enteric enteritis is being very common, and later on they can go for the enteric vaccination. But pneumococcal vaccination and influenza vaccination is very, very important, especially before COVID vaccination takes place, so that by the time they get COVID vaccination, the rest of the infections are ruled out.
Thank you very much. It was a very enlightening session. I will just concluding remarks. So we all know the ABC of diabetes: A for A1C, B for blood pressure, and C for cholesterol control. But if at all we add COVID in it, so A sync for ACE2 receptor, the research which can be done in the future. Also BMI, B stands for BMI and basics of sanitization for COVID thing, and C stands C is for CRP or inflammatory markers or cytokine storm. If at all we see the last thing is D, that stands for diet or desaturation of oxygenation in a patient, vitamin D, and also D dimer, that is checking for desaturation. So it was basically a very nice session. Thank you, doctor, for an enlightening session.
What a wonderful, Sanjeev sir, all of our microphone were mute. So thank you for making that ABCD, Dr. Mikal, and indeed pleasure. All panelists, thank you.
Thank you.
Invite for moderate this session. This was wonderful.
All the best, Yash. All the best.
Thank you, Sunil sir. Thank you. Thank you, Manoj sir.
Thanks.
Thank you, Dr. Urman sir.
Thank you, Yash. Thank you, Mayur bhai. And thank you, all the faculties.
Thanks. Thank you.
Thank you so much, sir.
Thank you.
Have happy and early vaccination.
Bye-bye.
Happy and early vaccination. What a nice slogan. Yes.